Welcome to Bite Size Dental Marketing. In today's episode, we talk to Dr. Paul Homoly, a legend when it comes to patient communication and treatment acceptance. Now, here's the deal. You can have the best team and a stunning office and top-notch dental marketing, but if your patients aren't saying yes to treatment, then we all know that everything stalls and your business will not grow. Dr. Homoly breaks down exactly why that happens and what you can do about it as the owner of your business. We're diving into the psychology behind high fees case acceptance and the 4 chiefs that every dentist needs to uncover in a new patient conversation, and why trying to educate or oversell patients too early is actually driving them away from your practice. So if you've ever felt frustrated by patients ghosting you after you've presented them with a big treatment plan, or you're unsure how to talk about money and it makes your team feel salesy, well, then this episode will change the way that you approach case presentations forever. Enjoy. Welcome to Bite Size Dental Marketing. Today I'm joined here by the great and powerful Dr. Paul Homoly, coming to talk to us about what I believe is one of the most important things in dentistry. Dr. Homoly, you can have the greatest marketing, you can have an amazing team, the most beautiful office and everything, but if patients aren't accepting treatment, you're going to run into problems eventually, and that's why I'm excited to have you here today. Thank you so much for coming to talk to us.
Great. Outstanding. Well, you hit it right on the head. A lot of dentists invest, everything they have. They borrow money. They put their lives on hold. They ask their families to sometimes get on the sideline while they build their business. So they buy technology and facility and hire a bunch of team and throw in a bunch of marketing and take a lot of continuing education. And they're really all dressed up, ready to go. And those patients start rolling in. And the expectations of doing these larger cases, there's a lot of really good consultants in the world that can help dentists with the basics. But my work really starts at the $8, $10, $12, $15,000 level and up. And dentists invest a lot, especially in digital technology, to be able to predictably produce sophisticated, accurate, predictable, safe results for patients. But that takes a lot of infrastructure to do that. And so if they're not having the experience, Ian, a patient saying yes, then after a while they get powder burns from the whole thing. So you're right. Treatment acceptance, I would say treatment acceptance is only slightly less expensive than oxygen to a dental practice.
And it is, I mean, you're spot on there, and I can imagine when you're going into treatment that's that expensive and you want to hit, of course, every dentist wants to do the big production cases. They want to work less and they want to make more money. But you need to be able to help the patient understand why they need it. It's not something you are forcing onto them. It is something that they need to do together. And one thing that I know you talk about a lot is understanding the motivation, the why of the patient. So for dentists out there today that are struggling with this, that are thinking, and they're saying, Dr. Homoly, please, how do we think about that why of the patient in your experience?
It's a great topic. Number one, the traditional dental school education, and for the most part, Ian, the traditional continuing education, publications, association meetings don't talk about the why. They talk about the what and the how. Here's what's wrong with your teeth, and here's how we're going to fix them. Here are the procedures. This is what's wrong, and this is what's wrong, and this is what's wrong, and here's how you got this way, and here's how we can do it, and it's going to take this long, and it's going to cost this much, and I'm going to let you talk to Julie, my treatment coordinator, and she'll get you fixed up. And the dentist kind of runs out of the room to grind on another tooth. And it isn't until the end of the day, and then he goes up to the front desk and say, well, how did Mrs. Smith do? And they say, well, she was going to go home and think about it. Right? And the truth of the matter is, for a lot of these high fee cases, when you simply tell them all their problems and then hand them a big price tag, they're not going home to think about it, and they're going home to drink about it. because you've given them another problem. The problem they had walking in is they had bad teeth. You give them a second problem. The second problem sounds like $20,000, right? So there's a different mindset that needs to go into treatment presentations for that higher fee case. Okay. And as far as discovering the why, you see, that is, that isn't in the traditional approach to the um, process of the new patient experience. For most dentists, the process is to educate, educate, educate. The new patient comes in and they zip off to the hygienist, and the hygienist does their thing, and maybe there's some diagnostics. And then the doctor comes in and examines the patient, and then there's explanations about this and that and the other thing. And it's all about the patient understanding the dentist. My work is the opposite. My work is about us understanding them. You see, there's a distinction. See, understanding patients, another word for that, Ian, is called empathy. It's understanding people, okay? And empathy and education are complete opposites. With empathy, with education, we want patients to understand us. With empathy, we need to understand them. And there's not a process for that. See, we have diagnostic codes for what we've got insurance codes and the ADA codes for diagnosing, understanding patients' condition. But tell me, what are the codes for understanding people?
Is it too mechanical for you in what you're saying in how dentists are approaching patients? You're almost like you're acting like an insurance company when you should be acting like a caregiver.
Yeah, exactly right. And understand now, this applies to the higher fee case. Once the fees get up to $8, $10, $12,000, that's when understanding why patients want to get their teeth fixed actually are a bigger motivator than patient education. Patient education is highly overrated when it comes to the high fee cases. And here's the reason why, Ian. For a patient who has significant dental disease, missing teeth, periodontal disease, speech problems, aesthetic problems, they already know they've got problems, right? You don't need to say, you have missing teeth. Your teeth look like hell. No, you don't need to say any of that. They already know. They don't know the individual pocket depths and the mobility charting of their teeth, but they do know they are unhappy. Now, the modest care patient, those patients that just need a filling and a cleaning, oftentimes they have dental conditions they are not aware of. Impacted third molars, periapical abscesses, incipient tooth decay. So patient education is really the driver of treatment acceptance for those cases that we'll just call it in less than $3,500. Patient education is the driver. Why? Because oftentimes patients don't know they have the condition, all right? But you see, once we get up to $8,000, $10,000, $12,000, it's less about education. And I'm not saying we're not going to educate patients, but what I'm saying, it doesn't have the same leverage as it did with the modest fee cases. For the higher fee cases, it's going to be understanding why they want their teeth fixed and when they can do it. So for the modest care cases, it's what and how. Here's what's wrong, and here's how we're going to fix it. And that's perfectly legitimate for that $2,500 case. However, for the $25,000 case, it's more going to be why and when.
I agree with this. I've done a lot of research on this. I've even built frameworks in how we do dental marketing of how you can convince someone to do something if you do it in the right way. And I'm not saying to trick someone. I'm saying exactly what you're saying. Yeah, I think about the 3-phase adult education plan, which I'm sure you are very familiar with as a clinician yourself, of how do we help the patient? We elevate their understanding of this is why you need to be doing this. And yes, it's going to cost a lot of money, but by the end of this, it's going to be phenomenal. But my question to you, Doc, today is, and I hear this all the time, Dr. Homoly, I hear you. We can figure out how we're going to answer the why. We're going to work with the patient, especially for the more expensive thing. But when I speak to a patient, it's just money, money, money. I just hear money. When someone calls, it's money. Do you accept my insurance? Money, money. What's your response to? You're always going to have patients talking about money, but how do you approach those patients to help them understand that there's a bit more to it, if that makes sense?
There's nothing wrong talking about money. Now listen, you see, it's common sense. The patient's got a mouthful of problems again. They know it's expensive. But what they don't know is how expensive. Now, if they're going to buy a car or a house or a pair of shoes or something, they're going to want to know, well, is this within my budget? It's perfectly normal for people to talk about money. But it's the dental offices that get all sideways on this. Oh, they're just interested in how much all this is going to cost. Of course, because that's the only thing they know how to ask about. So don't, if a patient says, well, I'm really concerned that this is going to be really expensive, I agree with them. I say, yes, most patients find it surprisingly expensive and time consuming. But I'm telling you, I would suggest you come on in, let's take a look, and let's see what will work for you. How does that sound? Right? You see, so I'm not going to try to overcome any objection. I'm simply going to agree with it. Is dentistry expensive? Yes. Is it time consuming? Yes. It's all those things. And somewhere in the culture of continuing education, Ian, we've been taught to get on this pedestal. It's not our role to convince people. It's our role to understand them. It isn't our role to sell. It's our role to offer. I've been lecturing for close to 30 years now. And one of the questions I've asked at every one of my workshops and seminars, I'm talking about hundreds of seminars, thousands of dentists, I'll ask this question. I'll ask, how many of you are reluctant to offer complete care to patients because you are worried that you're going to blow them out of the water from sticker shock? Or you don't offer complete care because you don't want to overwhelm patients with complexity. Are you ready for this? Over 70%, 70, they're reluctant to offer complete care. You see, why? Because they don't know how to deal with a patient who isn't ready. Here's another question I ask Ian. I say, for those cases that are $10,000 and greater, what percentage of these patients are ready to accept complete care the first time they hear their treatment plan? This is not a recall patient, Ian. This is a new patient, total fees $10,000 or greater. What percentage of them are ready to accept complete care the first time they hear their treatment plan? Can you guess what that percentage is?
Knowing what I know about how reluctant they are, I'll throw out 30% of saying yes.
Fewer than 10%.
Fewer than 10%.
Fewer than 10% of general dental patients are ready to start a $10,000 case the first time they hear their treatment plan. And I have reports from thousands of dentists. Now, does that mean every dentist is like that? No. There are many general dentists where that number would be 60, 70%. When you get into specialist practice, it's often higher. But I'm talking about the average general dentist, the family dentist, when he offers a $10,000 treatment plan, fewer than 10% are ready. So what does that mean? What that means that 90% aren't. What happens to that 90%? You see, oftentimes those 90%ers, they go home to think about it, but they never return. You see, sticker shock is inevitable, but losing the patient is not. The trick here is to offer care so well that even though they're not ready, they'll never forget how well you offered it. And when they become ready, they'll return. That's the deal. It's not about closing the sale. Don't talk to me about closing the sale. That is the worst. That is the worst approach to the high fee case. The lower fee case, maybe that's not such a bad approach. If a person has an acute infection or serious tooth decay or rapidly advancing periodontal disease, I'm all for creating urgency. Ian, if you knew what I knew about root canals, you would treat it today. Don't drag your feet on this. But for an adult patient, a 65-year-old patient who's missing teeth and the teeth are worn down. These are chronic conditions. They've had tooth problems for the last 30 years. And you creating urgency to try to close the sale, that's baloney. And they'll sniff it out as sales pressure and they'll hate you forever.
Yeah, and they'll leave. I completely agree. That's spot on. That is spot on. So I know you talk about the four chiefs. Now that we said we captured the problem, we know what people are struggling with. We know. I liked how you said we're talking at patients instead of trying to work with them. Your four chiefs framework. I'm a dentist. I'm going to have a good weekend. On Monday, I'm going to be back in the office. What does Dr. Paul Homoly want me to understand about this four chiefs framework to help me better approach this when I get back into the office on Monday?
Well, the four chiefs are my nomenclature around the structure of the new patient interview. So for a complex care patient, the four chiefs is the structure. See, in dentistry, there's a big drum roll around the phrase chief concern. And what's the patient's chief concern? And the chief concern usually is voiced in terms of a dental jargon. The chief concern is edentulous areas here, here, and here, right? And then that really constitutes, okay, we know the chief concern, now we can move on with x-rays. I'm saying no. The chief concern is an inadequate inquiry into the patient's mindset. So what I've done is I've created, instead of one chief, I created four chiefs. The four chiefs are the structure of the new patient interview. First chief is the chief condition. That's the same as the chief concern, okay? What's the condition? What is the intraoral entity or extraoral entity that they're concerned about? The second chief is the chief disability. Here's where it gets really interesting, Ian. You see, disability is the patient's emotional experience with their condition. The disability is never in the mouth. The disability is in the patient's lifestyle. For example, Helen, a chipped front tooth in the morning, big chip, distal incisor, half the tooth is gone. She works at the bank. She goes into the bank and she's seeing customers and she's hiding her smile like this and she's talking to people.
She's sitting like,
exactly.
Feeling, yeah.
The chipped tooth is the chief condition. The disability, the chief disability, is the embarrassment around the tooth, okay? So the disability is it interrupts the patient's lifestyle. The third chief often has to do with the why. The third chief is the chief benefit, the chief behavioral benefit. Now, when I say benefit, I'm not talking about clinical benefit. I'm not saying, well, we're going to reduce the tooth so we can improve the crown-root ratio and get it into the curve of speed. No, none of that. The behavioral benefit is simply the opposite of the disability. So in Helen's case, the disability is embarrassment. The benefit would be confidence at work, okay? Confidence at work. And notice, confidence at work is not in the mouth. It's in her lifestyle. That's the behavioral benefit right there. The fourth chief is the chief fit issue. Fit issues in our life circumstances that patients need to take into account before they can accept your care. Life circumstances like their budget and their work and their travel and their family and their health. There's a lot of things circling around that. And the more complex the care is, typically the more complex the fit issues are, especially for the older patients. You know, when patients get up to be 60, 70, 75 years old, their lives are far more complicated than a 40-year-old's life. Patients in that older age range, they have aging parents or dying parents. They've got siblings that got health issues. They may have health issues. When a patient has a heart condition or has cancer issues, you know, systemic disease for these patients, Ian, it's like having a part-time job. They put a lot of time going back and forth to hospitals and tests and this and that. It is an emotional burden on people, especially as they age. And so just knowing a chief concern, well, they're mandible and maxilla are edentulous. That's the condition. Let's just move on. No. What's the disability? How does it get in their way? 2, what is the behavioral, or 3, what is the behavioral benefit they're looking for? And that needs to be specific for their life. See, a stay-at-home person can live without teeth. They can drink soup and take vitamins and nutritional supplements, and they probably do halfway okay. But if they've got missing teeth and they're still vital and they want to go on, they want to travel, and they have a social life, then it becomes a huge lifestyle deterrent. And it's no longer simply about preserving alveolar bone through osteogenesis from the effect of occlusal loading on implants. It's giving them the confidence to smile at a party. That's the benefit. And so the 4th chief is the fit issue. How does this need to fit into your life? Is this something that you're ready to do now? If you're the patient and you've got a mouthful of problems, and I know your case is going to be $15,000, $18,000, $20,000, during this new patient conversation, this 4 chiefs conversation, I may even bring up, and dentistry of this nature is surprisingly expensive and time consuming. Is that a concern for you at all? And I guarantee you the patient is going to say yes. You see, that's the conversation that we don't want to have. That's the conversation dentists fear. They don't want patients talking about money because the dentist doesn't know how to talk about money. So I will bring the topic up first. See, if you bring up the topic of money first, for example, I say, Ian, without looking in your mouth, but listening to you, I would suspect that a case like yours might be anywhere from $15,000 to $20,000. Typically, it would take us about maybe 4 to 6 months from start to finish. Most patients can pay on, we have a payment plan they can work with. Does something like that work for you? And you say, oh my God, I had no idea it was that expensive. I said, well, Ian, that's why I bring it up. That's exactly why I bring it up, so we can look at these problems. Let me make this recommendation for you. Let me do a good exam, and let's sit down, and let me give you an idea of what we're looking at. And then we'll do this dentist review when you're ready, not a moment before that. Mm-hmm. Okay? And so you see how I dealt with the money issue. It is a process of empathy.
I think dentists should take that into consideration too, the psychology of their patients. Who are you working with? Who are you talking to? It matters. It matters. So I love what you're saying there. Acknowledge the patient, understand the patient, work with them, level with them. Do not try and make them feel something that they're not feeling, because they're not going to believe you. They're not going to trust you.
No, our role is not to convince people.
Exactly.
Our role is to understand them. Our role is to offer the care, but offer it in such a way that we don't blow them out of the water. Ian, let me kind of jump to the end here. Not the end of this interview, but let's jump to the foundational issue. I've been doing this for 30 plus years. And over the years, I've often, and I've seen all these different scenarios, solo practitioners. I work with the largest dental support organizations literally in the world. My work contributes to millions of dollars of collections every month for these folks. I've seen just about every possible configuration of general dentists. I'm speaking to general dentists now, and somewhat with periodontists and oral surgeons in the team approach, okay? And I've often wondered, is there a foundational problem to all of this? If we were to look at the whole basket of problems, the whole basket of challenges with this and that and insurance and money and all this, is there a foundational problem that if we can solve that problem, many of the other problems begin to go away? And I'm convinced the foundational problem that dentists have with treatment acceptance for the complex care patient is that the initial appointment for the complex care patient is highly emotional for them. And we try to transform it into an educational experience. They're cringing on the inside, especially these patients that have been away from dentistry for a long time. There's a reason that they've been away for a long time. A bad dental history, bad experience, They don't have the funds. Plus, going to the dentist, I don't like going to the dentist, let alone the patients, okay? I get it. And so when they do show up, they have all this pent up anxiety and they're cringing on the inside. Our job is to help them feel better, not worse about themselves. You don't get patients to feel better. You don't relieve the cringing by talking about how they're osteoclast or eating away at their alveolar bone. No, we don't educate people into being comfortable. The only way we can get people to be comfortable is to give them a sense that we understand them. What do we want to understand about patients? In this order, we want to understand how their dental condition is interfering with their current lifestyle. That's called disability. We need to understand the behavioral benefit. That is, what are they looking? How does dentistry need to improve their lifestyle on a very specific basis? Is it home life? Is it work? Is it social? How does better dental health improve their lifestyle specifically? And maybe most importantly, how does it need to fit into their life? What's going on in their life? If this patient's on fixed income, or if this patient's spouse is retired, or this patient just made an investment somewhere else. And in a lot of these big cases, Ian, it's not the first time they've had a rehabilitation done. They might have already spent $15,000 or $20,000 on their teeth, and they're showing up at the dental office, and you're going to lay another 20 or 30 on them. You see, you need to be aware of how it needs to fit into their life. God forbid you use sales techniques on patients. Again, maybe at the modest care level, you can get away with it. One of the sales tricks is to convert cost into investment. Well, Ian, if you're concerned about cost, if we delay treatment, it's probably more costly in the future. And is there any reason why you wouldn't want to reduce the cost now? Well, doc, I'm really concerned about how much it will hurt. Oh, I understand that. But, if we delay treatment, it's only going to be more complex, and chances are you'll have more discomfort. And if we want to eliminate more discomfort, is there any reason why you wouldn't want to go ahead and start that now? You feel how manipulative that is? And yet there's dentists that are doing that all the time, and patients are giving them the finger and walking out and never coming back. And the dentists think they're doing the right thing because they drank the Kool-Aid of some sales specialist that never sold 10 cents worth of dentistry in their life. And now they're telling us how to do it.
That's so.
You hit a hot button on me.
And I'll tell you now, I'm here to be honest with you. I will fall on my sword. Being in dental marketing, I've spoken to dentists about exactly what you have just said, especially when we're talking about the restorative cases of dental implants, knowing that the teeth will shift, knowing that the jaw can change. In my mind, as someone, I've been in this space for 5 years now, of course, this is why I'm learning from you. This is why I'm here.
Sure.
I would think also, okay, but if I don't deal with it now, it's going to, the problems will become more complex. And yes, maybe that's true, but what you're saying to me is, Ian, yes, that's true, but the psychology behind it is not effective if you say that to patients. Because I have recommended that, as I said, for the record.
Let me clarify something. Let me clarify something. When I was speaking about the sales techniques, okay, about, if you don't go ahead and do something now, it's only going to get worse. And then that becomes the motivation to do it, right? Fear, okay? All right. The whole idea of informing patients of the consequences of a lack of treatment do not belong in the case presentation. Those conversations need to occur in the post-exam discussion. See, we start with the four chiefs. So now we know the disability, benefit, and fit issues. Now we do the diagnostics. We do the examination, okay? Now I'm going to have the post-examination discussion. And during that discussion, Ian, I'm going to make the patient aware of all their conditions, the consequences of those conditions if left untreated in patients similar to them, and determine whether these patients are concerned about those consequences. So, for example, you've got missing teeth. And so in my post-exam discussion, I would say, well, during your exam, Ian, I noticed that you've got your missing teeth up here and several missing teeth over here. You know, patients like you who have got situations like you have find that over time, the teeth can shift, making the bite uneven and actually leading to more tooth loss. One of the leading causes of tooth loss is missing teeth. Does that concern you? So I am giving them the consequences of lack of treatment, but not in the case presentation. I'm doing it in the post-exam discussion. So in the case conversation, I'm not going back in because I've already told them the consequences. We are required by state law and by dental ethics that patients need to know all of the awareness of all their conditions, the consequences of those conditions if left untreated, the benefits, risks, and alternatives to the treatment, right? Now, what dentists try to do is they try to put that all in one conversation. We call it case presentation. It's too much. The patient's head just blow up. They get overwhelmed. It's too much information. So the place to handle consequences is not in the case presentation. The place to handle that is in the post-exam discussion. So you're doing the same thing, but what I'm not doing is I'm not creating urgency unless it's really warranted. Again, I would say you've got these missing teeth here and here. Patients like you who have similar conditions, you see, I'm not telling you that you are going to have these consequences. What I'm saying is patients like you have these consequences. That's called an evidence-based approach. And it's far more objective, it's far more scientific, and it's far more practical. And the truth of the matter is, oftentimes patients have conditions that don't deteriorate with time. Periodontal disease is an example of that. Periodontal disease can reach a point and then just stop. We've all seen patients who haven't had their teeth cleaned in 10 years, and the calculus is an inch thick, and they've got no issues at all, other than really ugly-looking teeth, okay? And so the whole idea of consequence, it's very dangerous. It's very dangerous to use a sales technique. And the most popular profession worldwide are teachers. Second most popular are salespeople. Now, what's the probability?
I was going to say prostitution.
Yeah,
I guess it's not.
I guess not. We grew up in different neighborhoods, I guess.
No, that's the oldest profession. Sorry,
that's the oldest.
That's what I'm thinking.
The most popular.
Yes.
and so sales. If sales is one of the top professions worldwide, what's the probability that the patient is a salesperson, or they used to be a salesperson, or they're married to a salesperson, or their friends are salespeople, or their name? My four closest friends all are in sales. They're all in sales. They're not even in dental. They're all in sales, and they know alternative of choice closes and how to overcome objections and how to create urgency. They know all of the tricks. Now, if you have a patient who has sales knowledge in your chair and you give a alternative of choice close, we can either start this week or next week. Which week is better for you, right? If you do something like that, they're going to sniff it out as a sales technique. And once patients feel sales pressure, guess what, Ian? They are gone forever. Now, am I saying don't create urgency? No. What I'm saying is that for patients with chronic conditions, orthodontics, missing teeth, long-standing periodontal disease, those are like the big three, right? Those patients have had these problems for years, and it's not an urgent situation for them. Now, the patient that breaks off a tooth and the pulp is exposed, or they've got a third molar that's blowing up, yes, create urgency, and chances are you don't need to because the patient is urgent before you walk in the door.
Why do so many dentists still get it wrong? This is why people like you are out there, but clearly this remains a problem. Like, what are these dentists getting wrong? What's wrong in their mentality?
They're not wrong. They're just untrained. They grew up in the culture, the educational culture in dental school is all about the teeth. It's not about the people at all. And most advanced continuing education is about the teeth, or implants or bonding. It's very technical. I've presented at every major meeting in the United States, all the major meetings, most of the state meetings, dozens and dozens of state association meetings. And if I'm on a multi-speaker program, like it's a 3-day program, um, almost every speaker is talking about some clinical topic. And it will be guys like me who will be talking about, the nuance of communicating with patients. And dentists, you know, dentists oftentimes see the case presentation as a sales process. I need to sell this case, or we need to close this case. You see, the problem resides there in the nomenclature, what we're calling it. It's not, you don't sell people into complex care dentistry, Ian. What you do is you invite them into care. You invite them in when they're ready. So, for example, this is a good example. Complex care patient comes in, missing teeth, periodontal disease, $25,000 case. It's the whole deal, okay? And during the new patient interview, the poor chief's conversation, remember we talked about that earlier, either you ask or the patient volunteers, they haven't been to the dentist. Well, doc, I haven't been to the dentist in, oh gosh, it's got to be 8 years, We just moved here from Scottsdale, and then when we got here, I was going to get my teeth cleaned, and then we got sidetracked, and I just had so much on my plate, and now I'm kind of between projects, and so it's been a while since I've been to the dentist. And then they get a mouthful of problems, okay? One of the best questions a dentist can ask for the complex care patient with chronic conditions that hasn't been to the dentist in several years is ask, why now? So it sounds like this. So Ian, you tell me, oh, doc, it's been a while. It's been several years, this and that. I say, oh, I get it, Ian. A lot of my patients have been away from the dentist for a while. But what I'm curious about, Ian, is what's going on now for you that makes dentistry important? Is this something going on in your business life or is it personal? Why now?
I'm getting married, Doc. I'm getting married now, and I don't want my mouth to look like this. We're going to be taking pictures, so that's why I'm here today. That's why I want to come and talk to you.
Good. I'm glad to know that. Then let's do this, Ian. I'm going to bring in my assistant, Suzette. I hit the button, Suzette comes in. And Suzette, this is Ian. Ian is very interested in having the appearance of his teeth. For his daughter's wedding, a lot of photographs. Go ahead and take the x-rays and the scans we normally do for people who are interested in improving the appearance of their teeth. And so what I've done is I've linked the value of the diagnostics to the behavioral benefit you're seeking. It's called prescriptiveness, okay?
I see.
So instead of telling patients, well, we take x-rays and scans on all our patients, you can say that to a modest care patient, but for a complex care patient, after you have discovered the behavioral benefit, you link the benefit to the diagnostics, so you make them prescriptive, okay? Does that make sense?
Yes, it does. It does. Because immediately I will associate it. I will associate it more with how I'm feeling. That's the point of what's happening. I will rely. Wow, this doc cares. This is what I need. This is what I need in my life.
That's what I was saying earlier, that the initial appointment is an emotional experience for the patient. We try to make it an educational experience. So if I was to say to you, Ian, we're going to go ahead and take some x-rays. I need to see your bone levels. I need to see the condition of your sinus, your basis bone. I need to see this and that. We're going to take a CAT scan, and it's going to allow me to look at you in 3 dimensions. You see, I'm making it about me. Instead, I'm going to make the diagnostics about you.
Make it about the patients. That's for the dentists out there. Make it about the patient. And I want to ask you, this has been a fantastic discussion, Doc. Thank you so much. I want to ask you, for the dentist that's listened to this now, that's still struggling, this has been amazing, but I just don't quite know how I'm going to apply this on Monday. What do you have in the works? What do you have in the pipeline? Do you have any conferences or things that you can share today with your business and things that's coming up that you can share with our listeners if they need that extra bit of help?
Well, today was not designed as you going going to your office on Monday or Tuesday and knocking it out of the park. Today is designed to kind of give you um, a breath of fresh air, some fresh thinking around the treatment acceptance process. And I would say if there's one thing that you should absolutely take with you, two things. Number one would be the initial appointment for the complex care patient is emotional in nature. Don't try to convert it to an educational experience for them. Take the time to understand their disability and their behavioral benefits. The second thing that you can implement on Monday for the patient's been away from the dentist for a long time, ask the why now question. Well, Ian, it's been several years. Why now? What's going on now that makes dentistry important? And the answer to that, 9 times out of 10, is going to be the behavioral benefit. The behavioral benefit is true north. That's where the rationale for diagnostics occurs. That's the rationale for periodontal treatment. That's the rationale for tooth replacement, is pursuit of why now? What's going on in their life now? Okay. And as far as, okay, you like what you hear, a couple things. Number one, you can go to my website. It's www.paulhomoly.com. And there's two things. One, there's an online curriculum called Treatment Acceptance Mastery. And it's a very popular program here in the States. And everything that we talked about and a lot more is in that. That's the online program. For students that want a live experience, I host 2-day live workshops in Charlotte, North Carolina. They're on the website. So what I do with dentists who want to come to the live workshop, I enroll them in the online program at no additional cost. So they can be studying the material months before they show up at the live program. That way, Ian, they come better prepared. They already know what the 4 chiefs are. They already know what the case conversation. They already know what prescriptive diagnostics are. All of that stuff.
I mentioned to you before we started the podcast, my dad's been a dentist for the last 35 years. And the frustrations he shares, the things, he owned his own practice for 25 of those years. The things that he's shared with me and stuff, I hear it in what you're saying. And I almost wish I could go back 20 years ago and say, because of course he was more of a traditional bread and butter dentist, and to go back
Sure.
to say, Dad, hey, this is how you should be thinking about this. But I agree with you that dental school and the continued education is not looking at this from a psychological side as much as they should. That is something we need to recognize in this space.
Yeah, and keep in mind, Ian, 25, 30 years ago, it was highly unusual for general dentists to be doing cases $10,000 and plus. Highly unusual. However, technology in dentistry has come 100 years in the last 5 years. Now we have got surgical guides, we got CAT scans, we got better bonding materials, better porcelain materials, better understanding of the biomechanics around dental implants. And so what's happened is that the technology in dentistry has just grown. But you know what hasn't changed at all is the nature of the patient. See, the nature of the patient is they simply want to be well cared for. And we get all tied up. What happens is that our language about technology and patient education, we camouflage what I call standard of caring in that. Patients will feel overwhelmed. Do not try to convert emotional experiences into intellectual ones. And 90% of dentists are doing that now. I'm not saying don't educate patients. I'm saying cut back to a pack a day. Spend more time understanding these people. It's not your role to convince. It's your role to understand. It's not your role to sell it. It's your role to offer it, but offer it in such a way that even though patients aren't ready for it, they'll never forget how well you offered it. And when they become ready, they'll return. That's my message right there.
And that is a perfect point to end the podcast and say thank you so much, Doc. If you can just take what Dr. Homoly said in that last phrase now with you, you are going to be better off as a dentist. Dr. Homoly, thank you so much. It was fantastic to talk to you. And I look forward to having you back on the podcast.
Outstanding. Thanks, Ian.